Anterior cord syndrome is caused by flexion injuries or spinal column fractures. The bony fragments of the vertebral column are forced into the anterior or the front part of the spinal cord. The anterior artery provides the vast majority of the blood supply to the spinal cord. When this blood flow is disrupted, the patient will present with paralysis distal to the level of the injury. This is accompanied by the loss of the ability to feel pain as well as temperature control. The sense of touch and the ability to feel vibrations does remain, however. Central cord syndrome is the most common type of spinal cord injury and accounts for almost 75% of all spinal cord injuries, as well as 20% of acute spinal cord injuries. The most common situation in which you'd find your patient in would be hyperextension of the cervical spinal area that results in swelling or bleeding to the spinal cord itself. Now, it's not commonly seen when fractures are involved, but is usually due to longitudinal tears of the ligaments that surround the cord. Again, this happens because of the sudden and excessive hyperextension of the neck. The syndrome is common in patients older than 65 years of age who may already have decreased mobility of the cervical spine from the onset of arthritis and other issues such as kyphosis. Just a matter of anatomic review, keep in mind that the motor fibers are centrally located with more cervical and thoracic motor tracts than you would find in the periphery of the spinal cord. It's common to see a loss of motor function in the upper extremities than in the lower, and the patient may or may not be able to sense pain or temperature changes. With your patient, they may also experience some bowel or bladder incontinence. For many, if not most, patients suffering from central cord syndrome, the prognosis is good, with a regaining of function being likely as the healing process takes place and the swelling and edema begins to lessen. Brown-Séquard syndrome may be caused by injury to the spinal cord resulting from a spinal cord tumor, trauma, or ischemia, or an infection or inflammatory disease such as tuberculosis or multiple sclerosis. In its pure form, now you're rarely going to see it, but you do need to be aware of it. The most common cause is penetrating trauma such as a gunshot wound or a stab wound to the spinal cord. Decompression sickness could also be a cause of Brown-Séquard syndrome. It results in paralysis and loss of perception on the same or the ipsilateral side of the injury or lesion, and loss of pain and temperature sensation on the opposite or contralateral side of the lesion. Proprioception is defined as the ability or awareness of the position and movement of the body. So if your patient were to close their eyes and they were to move their arm, could they tell you, relatively speaking, where their arm is? The loss of this would be the patient not able to tell you where their arm is located. This presentation can be progressive as well as incomplete. It can advance from a typical Brown-Séquard syndrome to complete paralysis. Now, the good thing, if there is a good thing here, is that it's not always permanent, and progression or resolution depends on the severity of the original spinal cord injury and the underlying pathology that caused it in the first place. Cauda equina syndrome is compression of the bundle of nerves that are located at the end of the spinal cord. Causes include trauma, secondary injury or edema, bone fragments, as well as hematomas in the lumbar region. Now, there are a number of non-traumatic causes for this syndrome that includes a herniated disc, cancer, or even infections. Cauda equina can result in the following symptoms. Paresthesia. Paresthesia is defined as the burning or prickly sensation that is usually felt in the hands, arms, legs, or feet, but can also occur in other parts of the body. Patient will often experience pain, especially in the lower back. The patient will often complain of a loss of feeling that progresses with time in the legs, the inner thighs, the buttocks, or the feet. Basically, it would be any parts of the body that might be situated or seated in a horse's saddle. Now, these patients can have bladder or bowel dysfunction that has a sudden onset. Once a patient arrives at the hospital, rectal tone is assessed, the absence of which is a high indicator of cauda equina syndrome. Spinal shock is a temporary condition that happens simultaneously with spinal trauma. The swelling of the cord often results within 30 minutes of the initial insult and can make it appear that the cord itself has been transected or cut in half. This edema causes an interruption in the nerve conduction that is distal to the site of the injury. The patient often presents with classic signs of spinal trauma that include paralysis and the absence of motor reflexes. They typically will not be able to feel anything distal to the level of injury, and the ability of the patient to regulate their body temp will be negatively impaired. These patients, like in others, will often be incontinent of bowel. True spinal shock is a temporary condition and will go away with a short time frame, as short as a few hours, or could potentially take several weeks. The speed at which the syndrome corrects itself is dependent upon how serious the injury is, as well if the patient has other types of concomitant problems such as a reduced immune system or immobility. Generally, you'll find a patient whose skin is warm, dry, and flushed below the level of injury. Male patients may also present with a priapism, which is a partially erect penis accompanied by the loss of bladder control. In neurogenic shock, injury to the spinal cord or the brain disrupts the brain's ability to control the body's autonomic functions. Because of this, lack of sympathetic tone also often results in vasodilation, reduced cardiac output, reduced strength of contraction, loss of control over the adrenal medulla, which no longer releases epinephrine and norepinephrine. Your patient will often have a relative hypovolemia with no compensatory mechanisms. Now, what do I mean by relative hypovolemia? Because of the dilation of the vascular system, the patient will appear as to being in hypovolemic shock, when in reality they have all of their fluid, all of their blood there. It's just simply because of massive vasodilation. Important concept to remember. Signs and symptoms include a slow heart rate, a low blood pressure, and warm and dry skin below the injury, and cool and moist skin above the injury site. Autonomic hyperreflexia syndrome is the body's response to neurogenic shock. It's commonly associated with injuries at or above T5. Signs and symptoms include sudden hypertension as high as 300 millimeters mercury with bradycardia, a pounding headache, blurred vision, sweating, and flushing above the injury site. Autonomic hyperreflexia is a medical emergency. The patient is at risk of developing seizures, stroke, or even death. Your best treatment of this is rapid transport to a trauma facility. There are several different types of transient syndromes, which are basically things that happen and they correct themselves. One of the most common is called a stinger. This is a sports-related injury to nerves in or near the neck or shoulder. It feels like a pinched nerve. You have painful electric sensation through the neck and the arm. You can have transient quadriplegia, temporary injury to the spinal cord with numbness, pain that has with or without weakness, and or complete paralysis or not. In a neck injury, trauma may result in airway, spine, or blood vessel problems as well as structural injuries. One of the things we want to be very aware of is trauma to the blood vessels of the neck. In these situations, hemorrhage may produce expanding hematoma that becomes trapped in the fascia and applies restrictive pressure to the jugular veins. Lacerations may result in hemorrhage leading to shock. We can also have an arterial interruption that leads to brain hypoxia and infarct, signs and symptoms of a stroke. Keep in mind that open neck wounds may draw in air and form an air embolism. Therefore, you need to put an occlusive dressing on all of those types of injuries. Larynx and trachea may sustain injuries that result in separation, fractures, or crushing injuries that can lead to hemorrhage, vocal cord contusion, swelling, or trauma to the epiglottis. Subcutaneous emphysema may present from tension pneumothorax, tracheal injuries, or penetrating trauma. Basically, with subcutaneous emphysema, it feels like Rice Krispies or air bubbles that are under the skin. If the patient sustains injury to the esophagus, this may cause gastric contents to spill into the chest. Now, keep in mind that the gastric contents are very, very acidic and can lead to damage just from the acidity of itself. If you got a patient that has a deep penetrating trauma, this could potentially disrupt the vagus nerve, causing tachycardia, GI disturbances, as well as injury to the thyroid and the parathyroid. The cervical region accounts for over half of all spinal injuries. Injury to C1 and C2 often result in fatal injuries. C7 is the spinal area that is most often injured because of where it is located. The thoracic and lumbar injuries are equally divided. The spinal cord itself ends at L1 or L2. Now, the actions that you as the paramedic take, or just as important, don't take, will have a direct impact on your patient. One study showed that when patients were immobilized on a long backboard, they spent an average of 54 minutes on the board from the time that it was applied to removal at the emergency department. It is possible for hyperextension of the cervical spine that can cause a neurological deficit. When you are restricting the patient, make sure that the head and neck are in a neutral inline position. Immobilized patients, and especially older patients, will often develop pain and skin breakdown in the occipital, sacral, and lumbar areas of the body that were not present. These injuries were not there prior to being immobilized. Patting the lumbar region and behind the knees can help to greatly reduce this pain. If available, use a commercial vacuum splitting mattress. These devices have been shown to cause less pain, and the patient tends to have less neurological deficits from immobilization. In addition to skin ulcers, improper or in certain situations, proper immobilization can increase the chances of respiratory compromise from the aspiration or exacerbation of pre-existing respiratory diseases. Think of the COPD patient who cannot lie down flat. If you apply cervical collar too tightly, an increase in intracranial pressure can result. You'll probably see a question on that for your exam. Since head injury is common in trauma and increasing intracranial pressure is associated with negative patient outcomes, this is something that you must avoid at all costs. In addition to the increase in intracranial pressure, managing the airway is made much more difficult with a cervical collar. Keep in mind to restrict spinal movement, you don't always need a collar. You can restrict, not immobilize, but you can restrict spinal movement without using a collar. There are times when that would be very appropriate. If you choose to use one, make sure that it fits well and that it is not applied too tightly so that it doesn't cause the problems that we've addressed in the last couple of minutes. As far as clearing patients for whether or not that they need to be on a backboard, basically what we're looking at here is that we're going to mobilize the head and neck if the mechanism of injury and patient signs and symptoms suggest injury. Neutral and inline position, basically for that, would be for immobilization, stabilization, and spinal motion restriction. Now, you got to be really good at your assessment skills. And we're going to look at our initial patient impression as formed from the patient's level of consciousness, their physical condition, and use the patient's response to your questions to build your impression as well as the index of suspicion. Spinal clearance is decided on injury mechanism and patient findings. Spinal clearance protocols based on emergency department protocols, and these include the patient being awake and alert times 4, no alcohol or drug influence, as well as no type of distracting injuries. Your patient should have a GCS of 15 and no significant fight or flight response. They should have no signs or symptoms of spinal injuries leading into, such as paralysis or numbness that they're feeling in any of their extremities. Research reveals that penetrating trauma is unlikely to injure the spinal cord or cause spinal instability. In these situations, do not initiate spinal precautions for this patient unless there are obvious and very, very clear symptoms of spinal cord injury. Not all patients need to be immobilized on a long spine board. Let's talk about a few of them that, if they're present, can preclude spinal immobilization. Well, first of all, obviously we want them to be awake and alert. Their GCS should be about 15, and they shouldn't be having any spinal tenderness or anatomical abnormality. No step-offs in the cervical area. They shouldn't be having any neurological findings or complaints. And again, no distracting injury. Keep in mind, a distracting injury is a really impressive looking injury that is usually not life-threatening, but can really draw the attention of the patient and you as the responder away if you're not careful. There should be no intoxication of alcohol or drugs. Now, if you're not sure, it's possible for you to use spinal restriction, which is very much different than spinal immobilization, by putting a collar on your patient and securing them to the stretcher rather than to the backboard. This type of a restriction would be indicated in a patient who's ambulatory at the scene and maybe those who have to be transported for a very long time, especially if you're doing an interfacility transfer. Patients for whom a backboard is not otherwise indicated include patients who have penetrating trauma to the head, neck, or torso, and no evidence of spinal injury. These patients should not be immobilized on a longboard. The most frequent sign in male of nervous system injury is going to be priapism, prolonged, painful, non-sexual erection of male genitalia that is due to the unopposed parasympathetic stimulation. In these patients, they will also frequently have loss of control of bladder. Midcervical sign may present with a hold-up sign. Arms rise to a position above the head and the shoulders. In these patients, you want to monitor the extremities for signs of neurological impairment. In rapid extrication and motor vehicle collisions, applying a spinal immobilization for your patient can be a really time-consuming process. And the research has demonstrated that it is, for the most part, very ineffective and in some cases can actually be harmful to your patients. Many EMS systems have significantly altered their approach to potential spinal injuries. Rapid extrication technique does not provide for maximum protection for the spine, but it does permit rapid movement of the patient with a spinal cord injury when other considerations demand it, such as we've got an airway, a breathing problem, or we've got exsanguinating hemorrhage that is occurring, and you're just simply not able to control it with your patient in the vehicle. Neutral inline position is very important in spinal injury patient care because it maintains the best spinal column positioning and the greatest clearance between the cord and the spinal foramen interior. If the patient feels any increase in pain or if there's a significant resistance of movement, immobilize the head and neck or other portion of the body in the position that you will find them. Various spinal clearance protocols have been developed and they have been proven reliable. The main protocol is one of the first American spinal clearance protocols, and it still today continues to set the standard for spinal clearance. If you have any doubt about the patient's potential for spinal injury or the patient's ability to accurately report, then you're going to use appropriate spinal precautions as dictated by local protocols. Now, when we're assessing our patient, the airway is always going to be a concern for patients who have sustained head, neck, and spinal injuries. Studies have shown that the presence of hypoxia and hypercapnia in the pre-hospital setting often worsens outcomes as well as lessens the survival of the patient with these particular types of injuries. You may have often heard the little mnemonic, less than 8 intubate. Well, I'm here to tell you that is a lie from the pits of hell. That is one finding that you're going to have, and you are going to utilize that finding as well as other assessment findings for your patient. Now, an airway device may, and I stress, may be indicated, but we're not going to go with an advanced airway solely based off of a number off of the GCS. Sedation and neuromuscular blockers may facilitate the intubation of head injury patients if you need to do so. You'll learn more about this in Med Emergencies 2, as well as David will help you within in the lab to do those. One of the most common complaints that you'll respond to is the patient with non-specific back pain. Most of these complaints, like I said, will be non-specific and generalized, and the patients will have no history of trauma or trauma-related cause for their pain. Most of the time, patients with back pain will get relief from it in about 4 weeks. Anytime a patient has pain that has lasted longer than this, they should seek medical attention. In patients who are older than 50, the pain could be caused by some type of tumor that may or may not be benign or predominantly an aortic abdominal aneurysm, especially if the pain that they are feeling is of a tearing sensation type. Upright posture causes a lot of stress on the lower part of the spine in general and the lumbar spine specifically. This is where most injuries or disease processes occur. Most low back pain has no known cause. This is one of the benefits that you have over the time that I spent early on in my EMS career, where we had Furno 2-man aluminum cots that we lifted either from the head and foot or from the sides to put into the back of the ambulance. And so one of the chief complaints that we see of paramedics and EMTs of my generation is that indeed that lower back pain because of the repetitive motion of lifting patients and let's be honest, not using the best lifting posture that would be possible. When your patient makes this back pain, non-traumatic back pain, as their chief complaint, getting an accurate diagnosis can often be really, really difficult. When you're called upon to evaluate back pain that has a non-traumatic cause, think about various disease processes, including deterioration of the spinal cord or the spinal column itself, as well as deterioration of the discs that lie in between the different vertebrae. When you're getting a history from your patients, pay close attention to the types and the amount of pain medicine that you're using to control this pain. Degenerative disc disease is common in older patients. As we age, the disc between the vertebrae will degenerate and fail to serve as a shock-absorbing property that it had when the patient was younger. Disc herniation could be caused by trauma in patients who have a pre-existing condition for this area of the spine. As I said earlier, it's most commonly caused by poor lifting techniques, which you as an EMS provider should pay close attention to, as it can and often does have a direct impact on the longevity of your career. When disintegration occurs, patients may complain of spinal tenderness along with a limited range of motion. It's not uncommon for your patient to have motor weakness as well. So what do we do for these folks as far as pain management? First of all, we can consider morphine. That's probably not the best. Keep in mind that morphine is an opiate used to relieve pain, to sedate, and to reduce anxiety. Now, it may mask signs and symptoms of a head injury and mildly increase intracranial pressure. Our big thing we're looking at with morphine is that it can also cause hypotension, respiratory depression, and because it releases histamine, it can lead into nausea, vomiting of your patient. Fentanyl. Fentanyl is a better choice in this situation. It too is an opiate narcotic and it provides immediate and effective pain control. It doesn't cause hypotension to the same degree as morphine, and one of the good things is the half-life of fentanyl is much, much shorter than that of morphine. So if you're running into problems after you've correctly given a dose of fentanyl, you're not going to have to deal with them, nor is the patient going to have to deal with them for nearly as long as what they normally would. Ketamine is an analgesic and sedative with predictable dose-related responses. Now, ketamine is good because it doesn't cause hypotension, but it can indeed raise the blood pressure and cause tachycardia. Keep in mind that if you put your patient into a sedative state with ketamine, they may go into what is known as the K-hole. Basically, they can have hallucinations, especially upon reemergence. Administration, if you have to sedate your patient, administration of a little bit of a benzo will help to minimize these types of hallucinations as a patient begins to reawaken. Other medications that you need to be familiar with that you won't be giving pre-hospital, but you may come into contact with in the hospital, include mannitol. Mannitol is an osmotic diuretic that draws water from the interstitial space and into the cardiovascular system. A good thing about mannitol is it may reduce cerebral edema, thus dropping intracranial pressure. Dextrose. You may give dextrose if you've got a patient that has significant hypoglycemia. Sometimes a low blood sugar is found to be especially detrimental to patients with head injuries. The routine use of steroids for the treatment of spinal injury are no longer recommended. With your patient, a fluid challenge is going to be your initial treatment for your patient. The fluid challenge is going to be very, very helpful because, again, what we're looking at in here is that your patient has massive vasodilation leading to a relative hypovolemic state. Plenty of blood is still there, but we've got to fill up the plumbing in order to raise the patient's blood pressure. Spinal cord injuries are among the most devastating encountered by pre-hospital providers. To decipher the often subtle findings associated with these injuries, you need to understand the form and function of spinal anatomy. Now, again, I want to go back and review this. A distracting injury is not the same as a distraction injury. A distracting injury is an injury to another body part or system, such as a femur fracture or a degloving injury that we talked about, that causes significant pain and discomfort that it significantly distracts the patient's attention, making him or her unreliable as far as getting an accurate patient assessment and history. A distraction injury is one in which there's a physical distraction mechanism that causes separation of the spinal column elements and potential spinal cord injury. Commonly known as internal decapitation, what we're looking at is complete removal or complete separation from the cervical vertebra. Primary spinal cord injury occurs at the moment of impact. Secondary spinal cord injury occurs when multiple factors permit a progression of the primary spinal cord injury, particularly edema and inflammation. This ensuing cascade of inflammatory responses may result in further deterioration as it puts pressure on the nerves as well as the vasculature. Now, as a paramedic, limiting the progression of the secondary spinal cord injury is a major goal of pre-hospital management of spinal cord injury. Immobilization of the spine continues to be a controversial topic in EMS, but not nearly as much now as what it was even 10 or 15 years ago, because the science and supporting research is clear. Not all patients need to be immobilized on a hard, long board. As a matter of fact, it's my opinion that only a minimal number of these patients need to be put onto a long backboard. Now, it doesn't render the long backboard useless. It's great for transporting your patients out of a house onto the stretcher or transporting them short distances. But putting your patient on a long backboard for an extended period of time is not good medicine. Currently, the best practice is to immobilize those patients whose clinical presentation indicate that they need such an emphasis here, drastic treatment. Drastic treatment. Let me say it again to you one more time, brothers and sisters. Drastic treatment. Keep in mind that the purpose of spinal immobilization is to prevent secondary injury to the area, and the last thing we want to do as providers is to aggravate or intensify those injuries or cause other additional injuries by unnecessarily and incorrectly applying the device. These actions that you take or you don't take will have long-lasting ramifications on the patient's quality of life after you have delivered them to the hospital. Make sure that you're using the best practices when immobilizing a patient. Incorrectly immobilizing your patient may result in a neurological deficit in your patient that may last a lifetime for them. And this is in those patients that actually need it. So make sure that you're taking your time and you're not going about with a haphazard method of how you are immobilizing your patient for the ones that actually need it. Hyperextension of the cervical spine that can occur during immobilization procedures can result in neurological deficits. You must immobilize your patient if it needs it in a neutral position. The other thing in here is correct cervical collar size is crucial. You must measure each patient for collar size. Rigid collars are out. Let me repeat myself. Rigid collars are out. Soft collars are what you should be doing so as to minimize restriction of the carotid arteries as well as the jugular veins that can lead to more blood flow problems in the brain. If you're going to immobilize your patient, pad behind all the voids of the body in order to reduce pain and pressure. Use blanket rolls between the legs and along both sides of the patient's body to fill voids under the straps. This helps to restrict motion and increase patient comfort. And this is especially true if you're putting a pediatric patient onto an adult long backboard. Doing so with this padding will make the patient feel more secured on the board and reduce the incidence of tiny movement during transport. There should be no gaps between the patient and the backboard or beneath the straps. Your strapping method is also important. The patient must be strapped so that he or she does not move laterally or axially. In other words, basically what you need to do is to make sure that you immobilize the patient's body first and the head last. So as if you immobilize the patient's head first and the patient starts to vomit and you tip the patient up on the side, guess what's going to happen? The body is going to move, causing potential damage to the C-spine area. Thanks for listening to this recorded lesson. If you have any questions on these, please bring them when we meet again in class.